Well, thank you very much for the opportunity to talk to you all today. This is a great example of how we can get together as both primary care practitioners and also hospital practitioners as well. And the ASPIRE study, which I'll have to thank my fellow researchers and especially Rachel's husband who came up with the acronym, is all about those health transitions. So I want to talk to you about the study itself and also where we've come to with recommendations and work to from, as Laurie was alluding to. So I'm very much a qualitative research novice and was helped along the way very much by Desley and Michelle from JCU and UQ, as well as the old Medicare Local that helped sponsor this project when we first got started. And it was a project that was funded via AFCRI, the Primary Healthcare Research Institute, to look at the interface between primary and subacute care. So to take it back to, I guess, an example of why we're doing this, and this is not an unfamiliar example of why we need to do subacute care and interface care better. Mrs. J was actually a lady that participated in the study, was an 83-year-old lady living alone with a supportive daughter who acted as her main carer, well known to a much loved and supportive GP, and had presented to the Cairns Hospital ED on several occasions following repeated falls, lastly with an increasingly painful right hip. Initial x-rays in ED suggested there wasn't a hip fracture, it was mainly a pelvic fracture, so rather than being referred to the orthopaedic team, came in under the medical team. And because the medical wards were full, she was transferred to a surgical ward as an outlier before eventually coming to a respiratory ward and then referred to OPRA, which is our subacute service. After coming to our subacute ward for rehabilitation and 2 days of hard work with our therapist, she was having increasing hip pain, and subsequent investigations confirmed a fractured hip, which she had all along, and she was then transferred to orthopaedics for surgical management. Luckily, we do have an orthogeriatric service, so she was taken back fairly quickly after her surgery, but then had a further 2 to 3 week stay, following by which time she was discharged home with community-based rehab that worked well. So a good story, but you can see that admission had with it about half a dozen transitions in care. She went from home to ED, from ED to one surgical ward, from a surgical ward to a medical ward, from a medical ward to a subacute ward, back to a surgical ward, back to a subacute ward, and then into a community service with 4 different teams of doctors all the way along. So you can see how things can possibly go wrong. So what was this study about? Well, this is really trying to have a look at older people that are disadvantaged by the current system. We know that geriatric evaluation and management services, which is fairly old terminology, but I guess is subacute care to try and reduce functional decline when people come into hospital. But it doesn't necessarily stop people coming into hospital. It might prevent recurrent readmissions, but it doesn't prevent that first admission, unless we do things about how those interfaces work in primary care as well. And it was timely when we started this study because Medicare Local had just started up and we'd just started an inpatient service. So we wanted to try and optimise patient outcomes. And the reason we tried to get Cairns to do this is there was very little research we found done on this interface type care in regional areas. It was often overseas and it was often in big metro centres. And we know that we saw back when we started the study a progressive increase in ED presentations, which has been maintained over the subsequent 3 years or so. And we know we have an ageing population. I think that's a great thing. I mean, it shows the success of health interventions in the last part of the 20th and the early part of the 21st century and should be seen as a great opportunity for better care. But it does mean that we're going to see projected increased demand for both primary and secondary care services over the course of the next 20 years. And we know that there's 3/4 of people within Australia wait longer than is considered acceptable to access GPs, and that's at the time of the research studies was one of the highest in Australia. So what were we trying to do? We were trying to look at those diverse care transitions of older people, so to look at how people experienced it and to try and develop out of that an understanding of the experience and perceptions of older people and their carers. as well as personal, systemic and local factors that impact on care. So what's happening on a local level from a primary, secondary, subacute, acute care, and how can we improve those care transitions? So as I said, I'm very much a novice on qualitative research and was guided by brains much better than mine on this, but we looked at a qualitative grounded theory method of a longitudinal case study design. And surprisingly enough, for me, in the quantitative world, looking at 20 people and a qualitative research study like this is one of the biggest studies of its sort. And we managed to collect 93 semi-structured interviews, made up about 36 hours of transcripts there, as well as reviewing charts, and we did some service provider focus groups, which some of the people in the room were participated in. What this shows us here is really the people within the study and the people that we see generally on our subacute ward were very similar. We had a good representative sample. Few more men than women, unsurprisingly, but that's because to be in the study you needed to have a carer, and as a frail older male you're more likely to have a female carer than the other way around. So we had patient interviews at 3 time points, care interviews at 2 time points, chart reviews and the service provider focus groups that then allowed us to do more in-depth analysis of the research study. Now, the way that you do this sort of qualitative research is you develop a coding framework to look at those key figures, transitions, processes and system encounters. And then using a qualitative software, NVivo, look at thematic analysis to manage what was in a fairly massive qualitative data set. And from that really develop case studies of those interviews of all participants to try and then analyse for themes. So what we found is that there were general themes that appeared to shape most of these patients' journeys. And I'll talk a little bit about the sort of 3 main pathways we saw people taking. But we managed to actually create a thematic profile for each individual journey. Look what's the same and what's different, and then also analyse that focus group data. So the sort of categories of experience that we saw really were disrupted, manageable and emergent experiences. And it's important to think a little bit about this. The disruptive transitions were where, as is perhaps understandable, a lot of times it was a crisis event, a sentinel event that caused someone to present to the hospital, and it was unexpected. But in the disrupted transition experiences, there was an unexpected precipitant, but very little, I guess, thought beforehand from either the patient, the carers, or indeed their general practitioners about what would happen at that point. And thus there was not a lot of thought about what should happen with those services. There were delays and gaps. People were unprepared as to what was going to happen. And thus there was very little navigation through the system. And that poor linkages and poor transitions resulted in a bad experience for both the patients and the carers. And you'll compare that to a more manageable transition experience. And this is very much the sort of plan B approach, is that, yes, again, you had someone who's often sitting on that physiological knife edge of a very parlous situation, but with a predictable and timely implementation of care. So they'd been through the system, they knew what services were available, the navigation to the right care at the right time in the right place was more predictable. And that plan B of, yes, we know that something might happen, and if something does happen, this is what we'd like to do. Let's hope for the best, but prepare for the worst. And that idea of agency, of actually making your own decisions, of not having decisions forced upon you by circumstances, but by working through. And this is very much in keeping, listening to Denise's presentation on young onset dementia. It's that idea of actually being your own agent, being your own agent for change. And then those sort of emergent care transitions are sort of in the middle, if you like. You've got people that are interested, both from a patient and a carer. They know that there's a crisis coming, but the lack of coordination and the lack of ability to navigate through the system means that you get that unmet patient and carer needs. So it's that silos of care. You've got an ineffective response by ourselves as health professionals because you've got no linkages between those different silos. You know, it's that old fallacy that everything primary care-wise stops as soon as you enter the front door of the hospital, and everything secondary care-wise stops as soon as you go through the outdoor. And that silos of care is what results in worse experiences. And this was very much kept in with the provider views as well. We had a great group of GPs, hospital doctors, allied health, community service providers who we worked hard, and Michelle really facilitated those groups fantastically. And it was really the issues of dislocation, the weakly connected agents of care, the fact that there were these pivotal touch points, you know, where people came to their GP with an emerging issue or presented to the ED, but it was somehow not connected. So we come up with a few key messages there, that there are multiple tipping points in older people's health trajectories that seem to go undetected. You know, ED is important, but sometimes GPs don't get the information back from EDs. ED doesn't necessarily get the information from the person's normal GP if they presented to another practice or a 24-hour service. And it's that tipping point that actually influences the subsequent transitions. If you can influence at the point where someone first presents with one of these emergent issues to either primary care or ED, you can make the most difference. And it's that potential that you can actually have feedback and education across the whole services. Most patients in this study had a regular GP. Now, this was not a group of people who were attending, you know, lots of different bulk billing GPs. This was a regular GP, and most of the people had a trust relationship there. But they seemed to say very much that it was about expertise and rapport and accessibility. But they saw it very much as soon as something became acute, they wanted to defer that decision to the hospital, which is something we need to work against, and saw it very primarily as a weekday relationship, more for the non-urgent and monitoring issues than acute emergent issues. And when we talk to the providers as well, very much GPs were identified as the primary point of care and the central point of care, but were often had difficulties when there was the ability to deal with some of the acute issues, and also I guess some thought about what was the function of the GP management plans. There was often issues that were identified by poor information exchange, particularly from the hospital out to general practice, as well as the evolving complexity and instability of systems as well. Knowing what's available and what to get for the patient at a particular time is a nightmare. I mean, I know you've had a talk this morning on myHCare, and I suspect even saying the words myHCare has caused the systolic blood pressure of the room to raise by about 20 to 30 millimeters of mercury. So, you know, we know that actually getting the right person to the right care isn't easy. Opera was seen as a touch point in care transition. So, you know, that idea of providing evaluation management service through a holistic and patient-centered approach was valued by both patients and their carers, and the fact that there was a bridge there between the hospital and community divide. But there was having said that, there was some disconnect in how, I guess, rehabilitation goals and plans are made. There was quite a difference between what patient and carers were wanting and expecting and what some of the allied health and nursing professionals on the wards were wanting out of them. And it's very much, you know, patient-centered or patient-centered care and goal setting is absolutely key. And it was, again, things worked well if everything followed the predictable path, but with people with multi-morbidity, multiple medications and a tenuous social circumstances, things rarely go according to plan. So the need for that plan B becomes more and more important. So coming to the recommendations wise, and this will talk a little bit about what we're planning from here. One of the first recommendations is about embedding that early intervention and prevention front up in primary care. So that comprehensive assessment and screening for treatable causes for disability. So if someone comes to you, especially with ED as well, and this is other work we're doing outside this project at the moment, we need to identify those people and look at comprehensive assessment and care planning. The way to prevent the reversible or at least ameliorable causes of disability is early identification and links with appropriate care. And it's important to realise here that this is both diagnostic work, so this is about identifying treatable medical causes, but also substituting care as well. And you can't have one without the other. So some of the things we're seeing with short-term restorative care programs that the Commonwealth's talking about bringing in are talking more about the functional needs without the underlying physiological process, and you have to have both. We need to look at strengthening the system interfaces by building on existing programs, and this is, we've got some opportunities. RMAC developed a wonderful resource over a decade ago now that looked at comprehensive assessment in hospitals, but really that sort of resource needs to be taken out across the whole of the spectrum of care. I think it's ridiculous in public hospitals that we can't involve GPs more in discharge planning, and you know, to me, a simple way of doing that, and we've put representations through the society for this, is about broadening the Medicare item that at the moment only works if you're a private patient in a hospital, doesn't work if you're a public patient. You can't charge those discharge planning kegs conferencing. And also broadening the scope of transition care beyond just a hospital service. So if someone deteriorates, at the moment, to get them in transition care, you have to get them into hospital. You can't actually institute something in primary care. Hopefully, short-term restorative care program might help that, but I'm not convinced as yet. And then enhancing those care transitions for patients and carers. So really looking at genuine, transparent and targeted involvement of carers and patients, not just lip service to care planning, and looking at those navigation roles. So, just to end up with a couple of slides before we end, because I know I'm the last thing between you guys and the end of the conference, so I'm aware that otherwise I'll see the sort of slow move of people hopping out the side door. So I just wanted to bring you up to date. This is a path from the Sahara to, I think, Timbuktu to Kathmandu almost. So older person's health enablement. So this is what we were talking about with Laurie, is the idea, I guess, of enablement to look at an integrative approach to care coordination within primary care for at-risk older people. So it's the idea of actually embedding community faces and located specialist geriatric clinics with I guess, interface geriatricians, which is a term that's used a little bit in the UK at the moment, and try and prevent avoidable admissions through care planning, essentially. So the idea, of course, is that the GP remains the central coordinator of care, and that an enablement coordination role will work with GPs, practice nurses, and with a hot clinic involving interface geriatricians at local practices, via telehealth or even at home, and possibly also with access to a therapeutic team. So key roles will be the GPs and practice nurses, the idea of an enablement coordinator role, which would sit within primary care, and then the interface geriatrician service as well. So we hopefully can self-fund it as well. There are item numbers specifically for geriatric assessment that will fund it as well, and work closely with the development of health pathways as well. So I'll leave that with those thoughts with that, and I'm happy to answer any questions. Thank you very much, everyone.